Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we're joined by Dr. Bincy Abraham. Dr. Abraham is the Distinguished Professor and Director of the Fondren Inflammatory Bowel Disease Program at the Underwood Digestive Diseases Center of Houston Methodist Hospital. We talked to her about hormones, probiotics, nanotechnology, choosing the right healthcare team and treatment, and how fun it is to be a gastroenterologist. Cheers. Hi, everybody. Welcome to Bowel Moments. I am Alicia, your host.
And I'm Robin, your co-host, and we are very excited about our guest today. We have Dr. Bincy Abraham. She is the director of the Fondren IBD program at the Underwood Center of Digestive Disorders at Houston Methodist Hospital, and she takes care of IBD patients all day. And she's actually joining us from her office after scoping patients all day today. So thank you for joining us, not even going home yet.
Thank you for having me. My only regret is I'm not at home drinking a glass of wine with you guys, with you gals, I should say.
Yes, we're also sad about that. But if you were drinking, what would you be drinking right now?
Ooh, a nice Napa Valley cab.
Ooh, lovely. That sounds great.
Yes.
Robin, I'm taking a page from your book today. I'm having a cider, so I've joined the cider club today.
It's, my pouch likes it so far, so I'm sticking with it.
Bincy, tell us a little bit about how you got involved in GI, and then also in particular, how did you get a special interest in IBD?
Yeah, so I can tell you, I have a long story and I have a short story. I'll give you the short version. It all started with me telling myself I never want to become a doctor because it was going to be too many years of studying and, too much work. But here I am. I ended up doing this anyway because I fell in love with what I do. And when I was looking into specialties, I actually told myself, I was going to become a cardiologist because my first job was in, a cardiology company or looking at cardiac equipment, et But then I met a gastroenterologist that, was having a lot more fun than the other doctors that I was working with or rotating with. This might actually be a fun profession. So I ended up switching and I really fell in love with it and did gastroenterology. And then, of course, it's like each stage in your life, you have to kind of figure out what you want to be when you grow up, but it almost never ends in medicine. So even after you got into internal medicine residency, then you have to figure out what subspecialty you want to do. So I decided on gastroenterology, but even after I got into gastroenterology, especially if you want to do academic medicine, you have to kind of have a little niche, on what you really want to focus on. So I was kind of debating, and then I actually met one of the doctors. She was at Cedars-Sinai at the time, Dr. Marla Bincy, and she came in as a visiting professor. And I got to meet with her. It was like one of those serendipity moments of, who knew that I would meet with this doctor who is an IBD specialist. And the first thing she told me is, Bincy, you have to do IBD because we need more females in this field. We need more women in GI that does IBD. And I said, okay, let me think about it. I started doing more research and, working with, patients and all that. And I really fell in love with it. And I've just been doing it ever since. And it's just been my passion in life to take care of patients that have inflammatory bowel disease. So that's my short version of the story.
So I want to ask you a couple of things. You see a lot of patients with IBD. Obviously, this is your specialty. So are there specific things that you do in your clinic to best care for people with IBD?
Gosh, where do I start here? So I can't take care of my patients on my own. I have a wonderful team that I work with that take care of all aspects of care, right? Not just like scheduling and all of this, but really take care of the full picture of the patient. It's not just their gut. There's a lot of things involved. And in inflammatory bowel disease and taking care of patients that are on different medications, especially biologics and small molecules and all these newer medications, we have to monitor them long term. We have to get labs. We have to do some imaging, colonoscopy scheduling. Some patients are on infusion medication. So I really have optimized it by having an optimal team in a sense. And also understanding that it's not just a gut disease, that this is an entire picture of the entire person, not just other parts of the body like joint and skin and things like that, but mentally as well. So I think we have to kind of take care of these patients as a person in general, like the full picture. But I think also knowing that it's a chronic disease, you kind of inherit these patients for life. It's very rare that, you see someone, it's like, oh, you have, I don't know, an ulcer, you take this medicine and it will heal up and I'll never see you again. This is a chronic disease and our patients are for life. And I think that's one of the nice things about it is that when I see someone, especially the ones that like transition, let's say from pediatric to adult care, and I'm seeing them as soon as they turn 18, 19, 20, etc. And now that I've been working for quite some time, it's so nice. Like I feel like I'm a second parent to them. I see them like graduating college, getting married, having kids. It's just been amazing to see them grow up and kind of be a part of their life, even though it's part of the medical aspect of their life, but getting them to a point where they're leading a completely normal life has been really rewarding.
Yeah,
I love that so much. I tell patients that they have to find doctors that are going to be their BFF because it's a lifelong relationship. And if you're going to a doctor that you can't go to, that you can't share everything with, be completely honest about what's happening in your body, then that's not the right doctor for you because you literally will be in a relationship with this medical professional for the rest of your life.
Right. Of course, patients move and all that. And we're always sad to see our patients, oh, you're moving to, I don't know, Michigan or New York or California. But it's amazing to see, oh, but I'm going to, have them come back to see you during my Christmas break, or I'm going to come, I have family here, so I'll see you every year at least. So it's like, oh, I can't even get rid of you if I wanted to. You're still going to come see me. But it's nice to, have that feeling that they want to come and see you again.
Yes.
I was going to say that speaks well for you that they want to continue to see you, even though they have the opportunity to go away as well. So
Right.
That's really lovely to hear. So I wanted to move to research because I told you right before we started recording that I did a quick little PubMed search on you to see what you were up to.
You're academically stalking me? Is that what you're doing?
Exactly. It's like the Facebook stalk, but it's PubMed stalking. I love that you do both patient care and research because I think that there's so much happening within our community and so many things are changing so rapidly. So it was kind of fun to see what you're up to. I'm going to start with microbiome because I know you had a paper published, I think it was a couple of years ago, about microbiome. What do we know and how does this actually interact as it relates to IBD? Because I know so many people are really fascinated by this. So what do we know about the microbiome and how people with IBD, what's different about their biome? What do we know about how it contributes to inflammatory bowel disease?
It's a very important topic, but I think the question would be, what do we not know about the microbiome? Because we don't know a lot, but we don't know enough to explain diseases fully. I think microbiome is a hot topic, not just for even inflammatory bowel disease, especially for inflammation of the bowel, but for a lot of other diseases as well. What we know for sure in inflammatory bowel disease is that the microbiome is different in someone who has an unhealthy bowel, if there's active inflammation going on. So if you look at the different species, the variety, and a lot of different things that we can look into, the microbiome looks different in someone who has active inflammation, be it ulcerative colitis or Crohn's disease, and someone who has a completely healthy, normal bowel, normal patient. Now, if you have inflammatory bowel disease and your bowel is healed up and you're endoscopically, like when you look in the colonoscopy, everything looks normal, then your microbiome actually looks more like a healthy individual. So we know that there is some abnormalities or changes or differences in the microbiome if you have active inflammation. Now, the initial question was, well, what came first? Was the inflammation that came first and that changed the microbiome? Or did the microbiome change first and that caused the inflammation or contribute to inflammation? And that's still a question we're still trying to find the answer to. So there's a lot of questions that remain unanswered in the microbiome analysis, evaluation, and all of that. Now, when we talk about microbiome, we have to talk about diet, right? Because we know that diet does play a big role in what our microbiome is composed of. And I think that's an important question because that's one of the number one questions I get asked by my patients on, gosh, what can I eat? Or did I eat something that caused my disease? And the answer to both is, well, maybe, or maybe we need to change something there. So so if you did stalk me right, we did do a systematic review of looking at all these pre-illness diets and was there any link to inflammatory bowel disease? And we actually did see that if you were eating more red meats or fatty foods, lower fiber, lower vegetable or fruit intake, you had a higher risk of developing IBD, both ulcerative colitis and Crohn's. But if you were eating generally healthier, low red meat intake, high fiber intake, etc., then you had a lower risk of developing IBD. So we know that, yes, having a good microbiome can protect you from getting bowel inflammation. So that's one thing to keep in mind. But once you have the inflammation, your microbiome is messed up. I'm not sure if we can fix that with diet alone in all cases. Now, there may be a subgroup of patients out there that if we do fix the microbiome by diet alone, especially more with mild disease potentially, that we may be able to reverse that inflammatory process and heal their bowel. Now, the problem is we don't have a lot of diet studies. And as you can imagine, a diet study is very hard to do because we can say, oh, well, I want you to eat healthy and, improve your microbiome by eating more fruits, vegetables, et cetera. And then the other guys just, you guys just do whatever you're going to do. It's like, well, our diet can change depending on where we are, how we, if we cook, if we go eat out,
Right.
how restrictive we are in what we do, or if you end up going to a birthday party and eating cake and cookies versus, if you're traveling. So it's hard to do a diet study and be very consistent with it. So there was a study kind of comparing the SCD diet versus the Mediterranean diet, and Dr. Jim Lewis was working on this and presented this, showed that both diets were actually beneficial in helping symptoms of patients that have Crohn's disease. And both diets in general are healthy diets, although the Mediterranean diet is actually a little bit easier to follow because the SCD diet has like very more restrictions and kind of harder to kind of keep up with. But they did this study by having patients get delivered foods, and so they don't have to cook themselves or make, have to confirm that they were actually doing everything accordingly. Because if you're busy working or studying, etc., it's hard to be able to like do a good meal prep and make sure you follow all the rules, etc. So if meals are delivered to you, it makes it easier to do that, type of diet. Yeah, so it did show benefit in that aspect. But the question is, does that benefit last forever? Or do we need, if we start eating junk food again, will it reverse the microbiome? So a lot of questions kind of remain unanswered in the microbiome component of it. Yeah.
I haven't had a colon for 20 years. And I've always been fascinated when people tell me you should do low FODMAP or you should do something else. And I'm like, well, my microbiome is not, I mean, I don't have a colon. So I know that my small intestine adapted to be able to absorb more water and that kind of stuff, so I wouldn't stay dehydrated. But does it also adapt microbiome wise?
Yeah, so that I think you bring up a great point, because first point is not everyone's microbiome is the same and will be affected the same way, right? So each person is different. And that's one thing with inflammatory bowel disease. Ulcerative colitis affects one person one way, and it could affect them a completely different way in another person. Same thing with Crohn's, and same thing with the microbiome too. Even though we know there are differences, someone's microbiome may look completely different with Crohn's, the small bowel versus someone with colonic or ileal and, small bowel and large bowel Crohn's versus ulcerative colitis, the rectum, only or so. So there's so many differences too. So someone who doesn't have a colon, we know that in the colon, it's like trillions of bacteria in there that lives there. In the small bowel, typically there's very little, like in thousands range or so. But once your colon is removed and you have like a J pouch, well, there is a little bit of stool that stays in the pouch to kind of store it, right, before, it goes through. And so there is a difference in the microbiome in someone who has a J pouch compared to someone who has a normal colon. And if you look at the microbiome in the small bowel and someone's with a normal colon, also the microbiome is different. Someone who has an ileostomy, so
right.
They can be completely different. So diet can affect each of those individual people differently as well. So what may work best for one person may not work for someone who doesn't have a colon or someone who has a J pouch instead. So that also brings probiotics, right? And we looked at probiotics, which are supposed to be healthy bacteria in general, the good bacteria that we should have in our gut. Well, it's very interesting. If you look at studies in Crohn's disease, there was actually no benefit in using probiotics in someone who has Crohn's disease.
Really?
Yeah. Now, comparatively, in ulcerative colitis, there may be some benefit if you have very mild disease or if your ulcerative colitis is under control, and it can help with keeping it in remission longer. Now, the best data that we have for using probiotics is patients that have J pouch and get pouchitis. So probiotics can actually help reduce the risk of developing pouchitis. Robin's taking notes.
Writing that down.
Let me write this down. Let me say that again. Love it. So best evidence for probiotics in someone who has a J pouch helps reduce the risk of pouchitis. If you had developed pouchitis and got it treated with antibiotics, then you want to add on the probiotics, and that can help reduce a recurrence, that you can get another pouchitis episode as well.
I had heard that one of the struggles with probiotics is really being able to get it down far enough to get it, because there's so much processing that happens between your stomach and your small intestines and that by the time it gets to your colon, your large intestine, it's kind of all gone. And so am I hearing this correctly? Did I just make all that up?
Yeah. Are you making stuff up in your maybe no. So it's a possibility, yes, that we have to have bacteria that's going to be viable enough to get through our stomach acid, right? Our stomach's pH is like 1 to 2, very acidic in there. So a lot of things end up dying off if you eat something, but there are still bacteria that can make it through, because otherwise we wouldn't get infections, right? Viral gastroenteritis or other bacterial infections where we get from eating food. So there are some, bypassing of that. But even when you're taking probiotics, we have to make sure that it's, for example, encapsulated to be able to go through the stomach, keep most of the capsule intact so the good bacteria can remain in and go through the rest of the small intestine to get to the colon. So it's absolutely something to consider in choosing a probiotic that will get there. Now, do we have lots of data analyzing how good different, probiotics do? Not really, because these are, again, supplemental treatments and not like an FDA-approved medical therapy, essentially. So there's a lot of issues with analyzing how great they are in a sense of bioavailability of these treatments, essentially.
And I think one of the struggles I would imagine too is, since it's not necessarily FDA approved, there can be vast variation in this probiotic versus this probiotic, or even like you got this batch of probiotic versus this batch of probiotic. So I would imagine it's hard to measure because of that as well.
Right. So you have to kind of stick with brands that you may know that have been studied. So when you look at probiotic studies, there's so many out there, but the problem is they're not like high volume. There's like small numbers of patients that are in the different studies. They're not always randomized, controlled trials. So we can say, here, this is a great probiotic I want you to take. It's going to make you feel better. Well, just the thought of someone telling you that, oh, this is something brand new and you trust this person, they're telling you to take something, you might actually feel better because there's that whole placebo effect.
Yeah.
And for any substance to be studied, you have to have a good randomized controlled trial. And since, Alicia, you're like an academic stalker, one thing, that's my new nickname for you.
I love it. Very proud of it. Yep.
Which is actually pretty cool. I think it's like a compliment to an academician, right? Like, oh, you're stalking my work. That's so cool. So if you look at randomized control studies, even like major medications, right, for treatment of inflammatory bowel disease, we see approximately a 30% placebo response rate. Isn't that amazing? Like, still to this day amazes me, because that means that whatever we provide to patients that have ulcerative colitis, Crohn's, etc., anything that we could give, possible 30% chance that, I should say 30% of patients may actually feel better. So we have to have something that works better than 30%. And that's the problem with smaller studies or open label studies to say, oh, this medication worked in this number of patients. Like, well, would it have worked better than a placebo tablet? And that's what we need to get more information on.
That kind of leads me to my next question, because the other thing I academically stalked you on is one of your newer articles that just came out was about nanotechnology and like nanoparticles. So this is the new way of drug delivery, is my understanding. And so, but this feels like a space concept. So can we break this down for people a little bit more? By people, I mean me, about what exactly does this mean? And is this already something that is happening? Like, are the new drugs coming out nanotechnology?
So the whole concept of nanoparticles or nanotechnology is they are tiny. You have to use a nanoscope, not even a microscope, because they only give you a micrometer, level of information. So we need a nanoscope to look at these particles. They're very tiny. So they're tiny, meaning they're not huge, and absorption may be better and all of this. So what we initially did was, this was based on mice studies, that we had mice that were treated to develop colitis, for example, versus having healthy colons. And we used these nanoparticles, very small particle substances, and used them to see, and we just inserted them like kind of like an IV into their bloodstream. And using those nanoparticles, it somehow got to the colon and reduced inflammation. I mean, it treated the inflammation with these particles. Now, this was just having these receptors on the particles that will go towards the gut, and it got to the gut and reduce inflammation. Now, how did it do that exactly? We're not sure. We think it has some sort of immune modulation of it, of the immune system there. So my thought was, if we can show that it can go to the gut to help reduce inflammation, could we even do this where we can put nanoparticle of medications inside this particle, where it can go to the gut and reduce inflammation directly there? So if you think about the medications that we have, sometimes they're oral medications that end up getting to the gut through the GI tract. They're IV medications, injectable medicines, and they have to work through the entire body somehow to get there and reduce inflammation. And some have side effects, and some patients cannot tolerate things because of adverse events, etc. But how about if we can deliver small amount particles? So it's not a huge dose, but that's enough because it's going to get delivered inside these particles directly to where the inflammation is. That way, there's not what we call these systemic side effects, where the side effects would be zero as our goal, but it's delivering what that medicine needs to do right where it's needed. And that's the whole concept of it. So when we evaluated this, it was in mice studies. But of course, in order for anything to get through for FDA approval, we have to go through so many phases of different things, right? So we have to kind of try it in mice first, kind of optimize it there, then move on, and then do eventually like phase 1, safety studies in humans first, and then phase 2 and phase 3. So it's a long process, but maybe in a couple of decades, or even next decade, who knows, it could be early as that, where we could be seeing nanotechnology in treating inflammatory bowel disease.
Oh, that's cool. It reminds me of our first show where I talked about the submarine that travels through people that we couldn't figure out which movie it is, but people have given us lots of options. I still haven't decided which one it is.
Okay. Was not the Magic School Bus thing?
That's somebody suggested that, but I'm too old for the Magic School Bus. So It wasn't that for me. For other people, that's what spoke to them, and that's okay. So I'm not sure why I know this, but there it is. So I know kind of one of the buzzwords in our community is precision medicine.
Yes.
So as you were talking, this reminded me a little bit of this idea of precision medicine or personalized medicine. So trying to get to a point where you're taking the whole constellation of symptoms from somebody and looking at maybe their microbiome, maybe their genetics, and trying to figure out how do you best personalize what you're going to do for that person. I mean, obviously this sounds ideal, but how close to this are we?
I think we're getting closer. Personalizing medicine, I think, is huge for inflammatory. I think it's important for all aspects of medicine, right? Because when you read textbooks of different diseases, sure, we understand. I mean, going back to medical school, right? I was like, okay, this is how this disease is supposed to present. When you go into actual practice and see patients, like, no way, like you didn't read the textbook that I read 20 years ago. How come your body's not doing all the symptoms that I read before? It doesn't even make sense. Realize that it's our bodies are just, I think that's what they call it the practice of medicine. There's like the science part of it, there's the art of medicine too, where we have to take all our book knowledge and then again individualize it to this person's not presenting the way I read you in my textbook, but something about it makes me think that this could be the diagnosis. Let me work it up further, and then you kind of get to that. But when we're talking about precision medicine, especially in inflammatory bowel disease, knowing that no two patients are alike, I think is huge importance. It's of huge importance to personalize treatment so we can get our patients to what they need to be on. for example, if you think about, IBD, there's ulcerative colitis, there's Crohn's disease, and there's Crohn's that can look more like ulcerative colitis. So we have to label them as indeterminate colitis. There's that, like there's where the disease is located, how severe the disease is, what the patient's symptoms are. It can be so different for different, groups of patients, right? So knowing that, and then patients come with their own other sets of problems, like some may have heart disease, some may have lung problems, some may have kidney problems. So what are their other, comorbidities, as we should call it? Or some may have another immune-mediated conditions. We take those into account as well. And then we have to take into account, well, is there some potential genetic involvement? Was there family history? And how did the other members of the family do? Are they presenting the same way? So we need to know that information. Although majority of our patients that we're seeing really don't have much family history, we're seeing what we call de novo IBD, where majority of our patients, there's been no prior family members within. They're the first one in their family to ever develop this disease. So we take that into account. And then there's the I guess not just the phenotype, but more like what we don't have in clinical practice is when we take biopsies from the colon or the small bowel or wherever their disease is affected, can we see what's causing the inflammation, right? Is there, for example, we talked about the microbiome. So what's the difference in that microbiome composition for that patient versus someone else? So that's something that we haven't got to in clinical practice. The other thing would be even on biopsies, is there a different, what we call cytokines, which these are like these inflammatory processes that cause inflammation. Does this person have more TNF alpha, which is tumor necrosis factor alpha, which can be increased with inflammation in other diseases, but also in inflammatory bowel disease? And if someone has high levels of it, maybe this person would be a good candidate for a TNF alpha blockade medication. If they don't have high levels of it, maybe that's not going to be a good medicine for them. And then there's so many other different cytokines. And if there's high levels of it, maybe this person should get the ones that blocks the highest level of that cytokine. So I think that we can get towards in the near future. I don't think that's going to be far away. I think that's something that we could be, looking forward to, or we can personalize it in that aspect. And then there's so many other things that we don't know yet, right? There's so much interaction between the microbiome and our immune system that we haven't figured out yet. We think we know some aspects of it, but we're still learning. So for example, we know that the bacteria actually interact with our immune cells or white cells that are in the mucosal layer of our GI tract. And what kind of talk is this going on there? And how are they communicating? And how is one bacteria telling the immune system in one patient saying, oh, I'm a good bacteria, leave me alone, you do what you need to do, versus for another person, the bacteria talking to each other, the immune system goes, oh, I don't really like you, this so-and-so bacteria, I'm going to cause you to die by killing you off, and I'm going to recruit more cells and tell my other memory cells to come over and attack you, and then it causes this chronic inflammation. But why is it doing it in that person versus not somebody else? Another example would be, someone who ends up getting diagnosed with the disease after getting an infection, right? Let's say they're going out to eat somewhere and maybe with a group of people, and they all get sick from whatever it was they ate. And then maybe everyone gets better after a few days of, diarrhea, nausea, vomiting, etc. But the one person in that group ends up never getting better, or gets better, but then ends up getting chronic inflammation. And that's what triggered their inflammatory bowel disease. But why did it occur in that person? Was it genetics? Was there a family history? Or if there wasn't, what was going on in their immune system that we don't know that triggered it, right? And that's something we need to really understand and learn, but we're not there yet. And so there's a lot more that we don't know that we need to find out so we can even make that precision medicine better. But I think that'll be the near future for us.
Out of everything that you've talked about today, I haven't heard anything about hormones and how they would affect it. I just find that for myself personally, like I got sick after pregnancy. Mm-hmm. That's when I had my first real flare and ended up in the hospital. And I noticed my symptoms increase also with my cycle. So is there anyone looking at that?
Yeah. So gosh, there's so many aspects of that question, right? So I think hormones do play a role. We did do a menstrual distress and IBD questionnaire for our patients. So we do have a study looking into that. We did find that, yes, so I want to make sure I answer all aspects of your, because several
Sorry.
questions in that
Sorry.
No, that's okay. That's great. This is great. So we did find when we did a questionnaire for our patients that, were still having their cycles and saying during your menses, do you have more IBD, symptoms? And we did see in general that during your cycle, our female patients tend to have more GI symptoms, which we know that in the general population, maybe, you're not feeling great during that week anyway. So that, yes, symptoms, but specifically for IBD patients, there have in general, most of them did say that they were having more symptoms, either pain or more diarrhea or maybe rectal bleeding, but when we analyze this further to look and see, well, is it really the hormones that cause the, cycle? And then of course you're more you're hypersensitive during that time anyway. Is that what's causing those symptoms to occur? Or are you really having inflammation, during that time? And what we really found is that, the symptoms may go up, but they were not really linked to having actual inflammation, objective evidence of inflammation. So I don't think that the hormones are necessarily triggering active disease during the time, but it may cause more symptoms. So we do know that. Now, as far as pregnancy is concerned, yes, I have seen several of my patients that get diagnosed after pregnancy. So maybe some of the elevated hormones during the time of pregnancy may protect you, but then things change and you're getting your hormones kind of getting back to normal, and that switch or change in the hormones may trigger some sort of immune response and causing inflammation. Now, why is that happening in some people, but not others? Because otherwise everyone after pregnancy would have some sort of immune condition, right? And that's not happening the majority of the population. So again, another question that we need answers to. The other thing we see is, if you look at not just IBD, but other immune conditions like lupus, rheumatoid arthritis, for example, we see that patients, let's say, that have already been diagnosed during pregnancy, actually their symptoms of whichever their immune diseases are actually get better during pregnancy. And then they actually could get worse after delivery because all the hormone change and all of that. So very interesting to see that. So something with the hormones we know do play a role in the whole immune system is activation or deactivation or downregulation. Now, when we look at pregnancy and IBD in general, overall, we always like to get our patients in remission before they start their pregnancy, essentially before they conceive, because that's what we know contributes the best outcome for the mom, obviously, and to the baby as well. Because if you're in a flare, like your body may not help you get pregnant because your body's like, well, I'm bleeding or I'm having diarrhea. You want to have a baby? No, I don't think that's going to happen. So once you do, get into remission, you're more likely to get pregnant. And then other thing we've noticed is that if you have inflammatory bowel disease, you're going into pregnancy, what we see is a 1/3 rule. 1/3 of patients generally stay the same, 1/3 do better, and the 1/3 do worse. But if you look back to see who was actually in remission, like deep remission, endoscopic remission, you actually tend to do well throughout pregnancy. So that's why we want to make sure that all of our patients trying to get pregnant are in remission by the time they conceive and go into pregnancy for best outcomes for mom and the baby. Now, one thing that we don't know is, Robin, you had disease occur after you delivered. Could there have been something going on when you were pregnant or before pregnancy that got even better and you didn't know anything any better until your hormones went down and that triggered something? Possibility, but we don't know, because it would be nice to go back in time and do a colonoscopy right before you got pregnant or something like that. But again, questions that we need answers to.
Thank you.
Isn't it also true that your microbiome changes while you're pregnant as well?
I don't know a lot of details on that, but I'm sure it does, because as you can imagine, the other thing is you may be eating differently during pregnancy too.
Right,
I remember both my pregnancies, I had different cravings. So your diet changes during pregnancy as well. So my academic guess is I'm sure it does,
Okay.
but I don't know all the details. I have not looked into that data. So I wouldn't be the best person to answer that.
That's fair. I did kind of give you that curveball question there.
But Alicia, since you brought that up, I do want to clarify those. Any patients are listening into this, they're like, oh no, after I deliver, I'm going to end up having a flare. Actually, no, don't stress out. I do want to clarify that if you go into pregnancy doing well, then and knowing you have the disease, then you will do well after delivery as well. The other thing is medications that you're on want to keep you on it during pregnancy, because if you're on it and you deliver, then you're going to do well. I think the most concern concern I have, or most issues I see, is if a patient ends up stopping their therapy during pregnancy and then they deliver and then the medicine's not in their system anymore, then they can go into a major flare. And actually, majority of the medicines that we use in inflammatory bowel disease are actually safe to take during pregnancy and breastfeeding. Some of the newer small molecules that came out, we don't have as much data. The main contraindication drug is methotrexate, but most all the biologics that we use are safe. And I think that's another concern that patients have is, gosh, I don't want to be on these medications. Well, actually, the studies and the data show that if you stop it and you end up in a flare, then you and baby won't do well. But if you continue it, you and baby do well.
Yeah, and that was the piano study, right? That was that
piano
followed a lot of people for a long time, and it was a big study. So
it's still ongoing. We're still following our patients too.
Wow,
yeah,
that's cool. I like the women's side. So let's stick there for a second. A lot of the things that I've seen around women and inflammatory bowel disease really focus a lot on pregnancy. But as somebody who's nearing the other side of the world on that one, I am curious, is there anything that you see that happens with women going into menopause? So this sort of flip that coin.
Yeah, so we haven't really seen too much, which is actually a good thing, because on the flip side of things, well, what I can say is in general, so there's always exceptions to the rule, right? People that don't read the textbook, that if you actually end up developing inflammatory bowel disease, the older you are, generally tend to have more of a benign course or less aggressive course compared to if you were diagnosed at younger age. So the general study cutoff has been like less than 40 versus over 40. But we see, in pediatric onset IBD that it can be like a more aggressive phenotype because, disease or immune system is more robust the younger we are potentially. But also you have longer time, decades of your life to live with the disease. So more time for potential complications can occur unless your disease is under control pretty quickly. So there's that component of it. But as far as menopause, there's been kind of mixed studies of if patients end up, having flares or not. But overall, my own practice, my clinical experience too, we haven't seen any major changes in the disease course after menopause or around the time of menopause, actually.
Yes, as someone who is approaching that, thank you for answering that question.
You're welcome.
And reassuring her that she doesn't need to worry about anything else. Although Robin is the textbook example of not following the textbook.
Yes,
so
I didn't read the textbook. I'm sorry.
Yeah. I should tell all patients to read textbooks exactly as is defined in all of the textbooks of all the different diseases, right? So we know exactly what to do.
I don't follow, but I usually say I follow directions well, but my body doesn't follow directions well.
Your mind wants to, but your body says, nah.
That's right.
You really need to sit your body down and have a talking to, I think.
Yeah,
I do.
This question, it might be a little left field. So if you don't want to answer it, that's okay.
Okay.
As you're sort of talking about like changes in things, one of the things I found super fascinating is I had a really long conversation with a woman who has done IBD work, but is currently at a cancer center. And so she is now dealing with a lot of patients who, because of the newer type of cancer medications, one of the side effects is actually developing something that looks really like ulcerative colitis. I want you to tell me why this happens. And I realize that is like the biggest question I could possibly ask you, but like what's going on? Do they know why this is happening?
So to clarify, there are medications that are becoming more personalized, I guess targeted treatment for treating cancers. Instead of like general chemotherapy where just suppressing the immune system and shutting everything down and causing all these side effects of general immunosuppression, they're doing more we call checkpoint inhibitor therapies. So they're like blocking specific checkpoints in cancer, metastasis and growth and all of that. And so they're very specific, targeted to those inhibitors. But what we're seeing is, since they've been using it, and mostly like for melanomas, for example, or one of the main cancers that they're targeting, we're seeing that patients are getting on these medications are getting what we call checkpoint inhibitor induced colitis.
Okay.
So they're getting inflammation of the colon because this pathway is somehow being blocked by these treatments. We don't know exactly what's triggering it. And again, it's not happening in every single patient that gets these medications, but only a subset. So a lot of questions, again, that haven't been answered. There's more room for research there. But yes, so Dr. Mimi Wang's been working on this, and she's moved here to MD Anderson's from Cleveland Clinic, and she's actually using, and we're now it's kind of standard of care based on our guidelines of treating these checkpoint inhibitor-induced colitis patients is with medications that we use to treat inflammatory bowel disease. And it's working quite well in those patients. So we just don't know what triggers it again. Something with the immune system that's blocking that pathway kind of gets overridden and, causes inflammation in the colon. And sometimes, you may have to stop or hold the treatment for the cancers. And of course, cancer is going to, can kill you faster than a colitis can. So very important to kind of look at, okay, what we need to do first and foremost for the patient, but you don't want to have the patient taking a medical therapy is going to save their life, but their quality of life is miserable because they're living in the bathroom either. So we got to treat that. And we have for mild cases, we can avoid the IBD type of treatments, but in the more moderate to severe cases, then they need the IBD treatment to get them under control.
Yeah, I mean, it doesn't sound like it's a huge epidemic of people suddenly developing this, but it's enough people that they're like, oh, this is curious. And so they're doing some specific research on it.
Yeah.
Okay. Yeah, I just thought that's so interesting. And especially since the treatment, it seems like it's working so well, so much better than chemotherapy and radiation and stuff. So it's kind of like, wow, we want to keep going, but there's this weird thing. You've mentioned sort of some of the other types of things that can happen with Crohn's disease, including like skin issues, arthritis, eyes, stuff like that. So how do you as a provider make sure that you are building a team of people outside of your own world that can help your patients with these things? Like, how do you make sure you're finding people that are really versed in what this is as it relates to inflammatory bowel disease?
Right. So it's good to have a team of outside members, not just gastroenterologists managing your patient. I think the key specialist would be colorectal surgeons because we're working with them all the time for surgery. However, we need medical experts in rheumatology, dermatology, hematology, so many other areas as well. Ideally, in an ideal world, I would like to have an inflammatory bowel disease center where I have my IBD dermatologist next to me and IBD rheumatologist, specialized rheumatologist next to me, et cetera. But that's not, how the world works. And of course, patients don't just live here. They come from afar to come to different IBD centers for treatment as well. So we have to find other specialists that lives closer to them, as well. So that can be a challenge, but I think the key is once you kind of start, referring patients out to know, okay, who is an expert in their field. And ideally, you would like to have them in the same center so that they, you can kind of talk to each other and kind of have a multidisciplinary type of management for them. Now, often that's not always possible, but to kind of counteract that, we actually have a multidisciplinary IBD conference that we hold like monthly to discuss some of our complex or challenging patients to get everyone's input, the radiologist's input, the surgeon's input, sometimes the pathologist's input, and any others to make sure that have the right plan for them. And I always tell, my trainees and everyone, any of my colleagues, when we have some challenging patient, you don't have to do it alone. Talk to someone else. And it's good to have like a team, and it could be a different team every time, depending on the individual patient, but getting someone else's thoughts, with the challenging component of the patient care really helps out. And often it's just a matter of talking to someone going, I think this is what I want to do, but I'm not sure if I should go do the A route or B route. I'm thinking going the A route. And 90% of the time they're like, oh, I completely agree. I think go the A route. And they may add a little bit of additional reasoning why. Sometimes they might go, well, that's a good idea, but how about this or this? Have you thought about? It's like, oh, I didn't even think about that. Let me, consider that. And, you can go that way. So I think it's always good to have different brains in the game of, managing our patients, because it really helps to even just run someone's case by them and go, okay, I just want to get your input, making sure I'm doing this the right way. And even though I'm considered an IBD expert, I've been doing this for so long and managing only IBD patients, I still ask for help from others. And it's good to know that you don't have to go about it alone and just talking to someone else. And it doesn't have to be another gastroenterologist. It could be a surgeon or a radiologist to get that information that you need specifically to take care of that patient always been beneficial. So yes, absolutely getting other subspecialists on board, and especially that they have expertise in immune conditions, always going to be helpful than someone who doesn't have as much expertise in them.
Got it.
I want to dial it back a second because you're talking about subspecialists. So in 2018, after my diagnosis changed from indeterminate to Crohn's, I actually changed primary cares too, because I do travel to go see my GI, and my GI offered for me to still see a local GI and she would just work with that person. But I was not going to do that. I said I found my person, my BFF, my GI BFF. But I did change primary cares to find somebody who was versed in IBD. And when I went to see her and explain what happened, my diagnosis changed. Like, she scheduled me appointments every 3 months at first to keep up. And because of record sharing now, she can see everything that is done at my GI's office. And so when I go in to see her, she knows if I've had blood work or if anything's changed or if there's any new test results or anything. So even so far as just as a patient having a primary care doctor that is familiar with IBD, I have found so beneficial, especially since my diagnosis changed. And she was able to, I'm sorry, I didn't mean to interrupt you, but after the surgery in December, when everything went wrong and I went back home, and she was able to be my ringleader and get me, help me get in to see a cardiologist and a pulmonologist and all of those things at home. And those people were also familiar with IBD. So my pulmonologist automatically did the CT scan and looked for Crohn's related lung disease, in addition to, my lungs healing from surgery. So like, just having that first line of defense, primary care doctor being familiar with IBD,
that's fantastic.
Saved everything. So,
and you bring up a great point too, Robin, that I think for any patient listening in, that if you are not comfortable with the provider that you're seeing, it's okay to change. And I also tell this to my patients, I'll tell them, if I don't feel like I am the right person to treat you, then I will refer you to someone else. And, in IBD, when you become the expert at something, you kind of be that go-to person. But there are sometimes patients that I don't know how to manage because it's a strange complication of the disease, like a specific pouch issue. And I have patients I've sent over to our international pouch expert, Dr. Bo Shen, because I can't figure out what's going on when I've done everything that I could think of to assess. And that's been the best thing for the patient. Someone wants to get a second opinion, I'm always please do, because you can get a fresh set of eyes on the problem. And it's one thing, if you've been taking care of someone for a long period of time, you kind of know the person, the history and all of that, but that doesn't mean you should stick with that person, for forever either. If something else needs to be considered, or you want to get a fresh look on something, all the more go get a second opinion. Yeah, because it's good to get that information, because if you get the second opinion, that second opinion physician or provider says, I completely agree, then you have two providers that tell you the same thing. But if the other person goes, well, it's that you could do that, but there's also plan B and C that you could consider. And it's the other doctor didn't mention that. Okay, well, that's good. And what is B and C? And if I have any of my patients go to see someone else and they come back, say, oh, and the doctor said, B and C would be great. And it's oh, that's a good idea. Or no, I think B would be okay, but C would not be great because of X, Y, Z factors. And at least, we can explain that too. So I think it's good to, and for any patient listening in, it doesn't have to be IBD, right? It could be, but like you said, your primary care doctor, anyone else. I think, I'd say this because I'm a gastroenterologist, go with your gut instinct. It's something.
No, I don't trust my gut. That thing's backfired too many times. No.
I meant it in that, you feel like something is wrong, go, follow that instinct, because it's telling you, your body is telling you something.
Yeah.
Your gut may be telling you differently from your mind, but follow it. Yeah.
Robin's gut lies, unfortunately. You can't trust hers. But
IBD patients' guts lie all the time.
That's right.
And I'm saying this scientifically, Alicia, because if you look at the studies, if you look at symptoms, clinical symptoms, and you look at endoscopy scores, zero correlation, no correlation.
Oh, wow.
Some people feel well, but their colon may be a mess, or small bowel may be a mess. Some people feel miserable, but their GI tract may be completely normal. There's so many factors to it, right? So so guts can't lie.
I say my blood lies too, because at first,
Mhm.
when I first started feeling bad again in 2018, your blood work looks great. It's perfect. I'm like, I'm telling you something is wrong.
Yeah.
So, even once they started doing tests, then they were like, oh yeah, something is wrong. But my blood was like, we got this.
So your
I'm
gut
perfect.
so your gut didn't lie. There's something, right? Your instinct said something is not right, and you followed it. So yeah.
Yeah. One of the things that's come up on a couple of podcasts now, I think 3 different podcasts, is colon cancer risk and inflammatory bowel disease. So I want your very fast answer around what should patients understand about their risk of colon cancer and what should they do about it?
So yes, having inflammatory bowel disease does put you at increased risk of getting colon cancer. In general, that increased risk happens about 8 years from the diagnosis and moving forward. So the longer you've had the disease, the more the higher the risk of colon cancer over your lifetime. Now, again, there's always exceptions to the rule, but what we do know is that you can reduce that risk of colon cancer by getting you into healing. So the first step is, of course, feeling better and going into remission, but that's not enough. If there's still active inflammation going on in your colon, that can lead to colon cancer over time. So that's why we keep emphasizing, well, you may feel okay, but we have to get the colonoscopy to make sure you've healed up. And if you haven't healed up, that continued chronic inflammation is what's making changes in the DNA over time and causing mutations that leads to colon cancer. That's why it's important, that we get you feeling better and getting you into what we call remission endoscopically, like healing, so that can reduce that risk. But I think in general, we need to go further than that. And this is maybe the near future of treating IBD. Like all of our guidelines say we have to get to endoscopic healing, meaning visually things look healed up. I think we need to go a step further, like that's our gold standard, but I like to deem it like our platinum standard, where we need to get to what we call histological remission, meaning under the microscope, there's no more chronic inflammation. Even though visually it looks okay, there's still inflammatory cells that can still trigger some DNA mutations over time. But I think if we get that to deep remission with histological remission under the microscope, under histology, the pathologist can't even tell there's inflammation, that's what's going to reduce that risk of colon cancer. So what I do in practice is our standard guidelines say 8 years from diagnosis of ulcerative colitis or Crohn's of the colon, Crohn's colitis, you need to start doing surveillance colonoscopies. If you still have inflammation, you need to do those colonoscopies about every year annually thereafter, because having inflammation puts you at risk. But if you don't, then you can go out to about 2 years, every 2 years after that. But if I have someone in deep or histological remission, I'll move them out to every 3-year colonoscopy. So that kind of reduces, you having to come in, at least 1 more year for getting a colonoscopy done.
Thank you for answering that.
Yeah. And the other thing is, though, a little caveat here, if you have IBD and you have a disease called primary sclerosing cholangitis, or PSC for short, you have an increased risk of colon cancer immediately from the diagnosis. So you need to get annual colonoscopy. So no waiting 2 years, no waiting 8 years from diagnosis. Every year you get a colonoscopy, because you have a much higher risk of colon cancer if you have both primary sclerosing cholangitis and inflammatory bowel disease. So you need to be monitored routinely for the rest of your life for that.
And it's just based on our previous conversation, it sounds like we can't rely on blood tests to tell us that you're not currently inflamed, unfortunately. So you got to have a colonoscopy, it sounds like.
Right.
Okay.
You can check for stool markers for inflammation. There's 2 markers called fecal calprotectin and fecal lactoferrin. Both are really good to check for GI tract inflammation, but it won't tell you if you have polyps or not, if you have cancer or not. So we really need to make sure that we go in, take a visual look for polyps. And typically colon cancer, it's not the same way that the cancer progression occurs in like the general population. So, you can have these what we call flat polyps. And so we have to be very careful in looking at the colon. We tend to take more biopsies when we do a colonoscopy for IBD patients. Sometimes we do some special techniques like chromoendoscopy or narrowband imaging, where we can kind of look at the difference, the color of the mucosa, to look for subtle polyps as well.
Okay, lots to think about. But if you have a gastroenterologist that's versed in inflammatory bowel disease, they're going to be looking for all of this.
Yes.
You don't necessarily have to track it.
Just to make sure you get your colonoscopies done timely.
That's right. And if you listen to the episode where I said I had just looked at the American Cancer Society website before we chatted, had our conversation, and I sounded a little frantic about colon cancer, just disregard that. And please listen to Dr. Bincy Abraham, who is a medical professional.
You were just very passionate about making sure that people were getting their colon cancer screening, Robin, and we always appreciate that.
I was.
Just out of curiosity, when you were talking about, because getting back to doing colonoscopies, we were talking about you had just finished doing a bunch of scopes today. Are they fun?
They are.
Okay.
It's different.
For you, not for the patients, obviously. Are they fun for you?
Yes. My patients love it. They're asleep and having the best nap of their life.
Yes. I look forward to the anesthesia. I do.
See, it's fun. They're fun for the patient. They're not fun the night before when they have to do the bowel prep.
This is true.
But yeah, I think of you're a Hollywood movie star and you're doing like a high colonic before the Emmys or something. And think of it that way, and then it'll be fun. You lose a couple of pounds. It's all good. Yeah.
Right.
So it is hard work. I mean, I am physically exhausted by the end of the day, but it's different. It's not like just seeing patients in clinic, which I absolutely love. It's different from typing notes. We're doing some physical work. We're looking at something. We get a sense of like satisfaction that okay, we took a look at this person's colon. We found out if there's inflammation or not. If we found a polyp, we were able to remove it and actually prevent colon cancer. So it is rewarding as well.
Yeah, sorry, that was a real off the wall question, but I was like, I just am curious if this was kind of a fun thing to do. From the doctor side of it, of course.
I must say, when I was a medical student, I was trying to sort out what I wanted to do in medicine. I do remember one of the key gastroenterologists that got me interested in this profession did ask me when I was in med school and I was rotating with them. So said, Bincy, do you like to play video games? And of course, as a student, you're like, this has to be a trick question. What is he trying to ask? And of course, you're a med student, so you're like, well, so my answer was, well, I used to, but since I'm in medical school, I'm studying all the time.
That's a good answer.
Yeah. So then, he took me to endoscopy with him and kind of showed me, like what he does. And it's like, so really, you should forget cardiology. You should become a gastroenterologist because we get to play video games all day. And it's like, what's he talking about? And until I saw him do a colonoscopy, it's like, yeah, see, we're just going through this tube. We're looking at the image like you're watching actually doing a video game, and we're just taking out polyps and stuff. So it is actually fun. It's exhausting, but fun.
That's awesome, actually, to hear you say that.
So technically, I'm playing video games all day. Well, for me, it's all day Wednesday.
Fair.
So the question that we have been very good about asking everyone is, what is the one thing that you want IBD patients to know?
Yeah. So one thing I would say is you are not alone. Yes, you're suffering from the disease, but you're not the only one who has suffered from it or are suffering, and you can get better. So for any patient out there, I want you to get support from your doctor, from your nurses, from your family, from colleagues, and from anyone that you may know that has inflammatory bowel disease. And if you don't know anyone that has inflammatory bowel disease, find out. And you can find out in multiple ways. You can ask your GI doctor. You can go to the Crohn's and Colitis Foundation. They have support groups. And I know it's hard because talking about the GI tract and having bowel movements and stuff, it's not like something that we consider socially acceptable. And it's more of like a hidden disease, right? Because if someone has cancer, it's easy to say, oh, I have cancer. Well, I shouldn't say that easy, but something like that where you can say, oh, I have cancer, and people understand. But when you tell somebody, oh, I have to leave I have to go right now to go to the bathroom. It's like, you can't really, so you have to run to the bathroom. How come this person's running to the bathroom all the time? Or how come they don't want to come out to us to eat, So it's really sometimes can be a challenge, but I think more people will be understanding than we think, right? But I think the more you talk about it, the more you realize like there's people out there that have inflammatory bowel disease that you didn't even realize that they had it.
Yep.
The key is you're not alone. And if you're not feeling well, talk to your doctor, because you really shouldn't have to live with your disease not under control. And I think there may be so many people out there that have symptoms that are not fully controlled and are afraid to talk about it to others. So if you're not under best control, go see someone so you can get better. Your quality of life should not be miserable with this disease. with the medications that we have and the treatments and even the surgeries that we have.
Yeah, if you don't feel like you're under control, talk to somebody who specializes in inflammatory bowel disease because they can probably help you.
And if you don't know someone else who has it, there are 3 million of us in the United States. So I'm sure you know someone that knows someone.
Talk about it and you'll find our community.
Yeah.
Well,
And it's
Bincy, this is just delightful to talk to you.
Yes.
Thank you so much for joining us for this episode. And I hope you'll come back and visit us another time because I think we have lots more to ask you. So
Yes.
thank you.
Thank you.
Preferably at home when you can have a glass of Cabernet with us.
Cabernet, there we go.
Yes.
Thank you so much for having me. It's always fun to talk to you both.
Hey, BM fans, we need your help. If you like this episode, please rate, review, subscribe, and share. Thanks.